مساء الخير يا جماعة. How's everyone? Okay, I assure you, and I know it's not a very good timing for you, but I couldn't guarantee a venue. And I had a session that, يعني, the previous 2 hours. I wanted to make it even before that, from 12 to 2 for your time, but I couldn't guarantee a venue. I never can guarantee because, all the halls are usually booked. Type. We are not going, this is not going to be long because we are not going to explain things in the last day of the year. So it's going to be basically about your exam. And instead of going through the book, I am going this time to go through the actual orientation, word by word almost, and sometimes I will find myself needing to go to one slide in a presentation or a part in the book, and here is where I will make the switch. Okay? So as you can see here, this is for the end of year, and the end of year is worth of 48 marks. What happened last year? I am trying all the time to try to not put too many marks on the written part because it is difficult for you and it's difficult for those who correct the exam. I just want to see how you write. So it's going to be this time 21 marks for the written short answer questions and 27 marks for the cross-matching questions. Now, what happened last year, I made 24 marks for the cross-matching, but I always want to put little marks on each item. So if you lose an item, you don't lose too many marks. But what happened is I had to make 48 cross-matching items. That was very bad for them, especially that the pathology exam is lengthy. So I decided this time to make it halfway, to make 0.75 of a mark on each item. This means 36 cross-matching. Now, on a previous year, I wanted to make very extended cross-matching. So we went until J. And I designed this special bubble sheet for this. I found this later on to be too severe for you. So what's going to happen is 36 items, meaning nine scenarios, 9 stems, okay, each having 4 items with 5 choices. So you'll go with the ordinary bubble sheet that is used for the MCQ. And the pathology, they did the same as me because we need to be unified on the paper. If I put 0.75 of a mark on a question, they need to do the same because it is just one bubble sheet that it's going to be correct. Okay? So about the exam, it will consist of 36 extended cross-matching questions worth of 27 marks, 3 short answer questions with subdivisions. So 3 questions worth of 21 marks about mechanism of action, uses, and explanations. Okay, so this is the mechanism of action exam. Remember last exam when I told you delay the mechanism of action? Now you memorize the mechanism of action. Now you go on your book, where is the mechanism of action? I will memorize it. I will memorize it. I will memorize it. I am sure now that you know all the book very well. Okay, especially those mechanisms of action that are quite lengthy. Okay, so you should memorize them by heart. Uses are uses, and I'm going to ask you, yalla kaman, let me give you this one, for uses. I'm going always to ask you about 4 uses. So you memorize the use very well. As for the explanation, you will have 5 explanations. Each is worth of 1 mark. Those explanations are mine. They come from anywhere in the book. They need your understanding. However, as I always do with you, I have tried to highlight the ILOs that are of much interest in this exam. So you will see the ILOs highlighted now. Extended matching consists of 4 stems to be matched, each with 5 choices. Each choice can be used once or not at all. The exam includes topics in the second year book until the end of the lipid-lowering drugs. As you know, this is the 208 module. Please refer to ILOs below. Concentrate on the ILOs highlighted in green this time. These are some helpful notes. I'm becoming very, very, very too helpful. Okay? So let's read the helpful notes. Just go. Do not memorize doses, but know the route. As I always tell you, I want to know if a drug can be used IV for emergency situations. I want to know that if a drug is only available orally, because as a doctor, you should be able to know whether you can use this drug intravenously or not. If it's not available parenterally, only orally, you should know about it. Rule of thumb: monoclonal antibodies are given how? How? Monoclonal antibodies are given how? Not necessarily IV. What is the more general word? Parenteral. Some are given IV and some more commonly are given subcutaneously because these are peptides. So these are rules about route. Route makes you a doctor. You know what you are doing. You know what you expect to see beside you. So, for example, drugs that can be given IV for emergency situations, drugs are given only orally. The fact that monoclonal antibodies are given by injection and very frequently subcutaneously. Explanation questions might ask why a certain drug. Okay, explanation questions are going to be new and are going to need you to be a clever person and make associations you have not made before. I might ask you, if a question asks you, explain why this is beneficial in so and so situation, it's basically asking you about the mechanism of action of this drug in that particular situation. Why is this drug beneficial in that situation? What does it do? Either its mechanism or the goal of therapy or the benefit I'm going to see. And of course, you are responsible for what's written in your book. So whatever this drug does in this situation, you just write it there. It's just the phrasing of the question. Why do you use this drug in so and so situation? The question might come as, why is a certain drug used in this situation while another drug is not used? So it's more or less, in other words, it's trying to compare the mechanism of action of the 2 drugs. This is used because it works on so and so, and it does so and so, and this is not used because it works in another way, and it doesn't do so and so. You have never seen this phrasing before. It doesn't require any extra knowledge. It just requires you to phrase and express your knowledge in a certain way. I might also ask you, why does a certain drug cause a side effect and the other drug does not cause a side effect? It might be due to certain kinetic properties, certain dynamic properties, receptor selectivity, different distribution, but you will have it in your book. It is not anything that's not written in your book. Yeah. Okay. How? Okay. Right. Those people online are doing us a big favor. They are telling us whether the sound is fine so that we guarantee the quality of the recordings. طيب, several types. I have a mic which is open. Please, we don't want this. I have made them all muted. Right. So why a certain drug might cause several types of drugs may be used to treat the same disease. So the goal of therapy is important. You have many drugs for heart failure. You have many drugs for angina. You have many drugs for migraine. You have many drugs for myasthenia. You have many drugs for shock. What does each of them do? What does each of them do? This is where the cross-matching will come. You should know which is good for what. A certain drug might cause one side effect, another one does not cause the side effect. Reasons may be dynamic or may be kinetic. Now, I have told you, you will read deeply. Certain drug, okay, blood is your most important chapter. You know what I think about blood. And I told you last time that as any doctor will use anticoagulants and drugs working on the coagulation and on platelets. And I'm telling you now, even the names are important. Perhaps the direct oral anticoagulants, the new oral anticoagulants, I want you to know rivaroxaban, apixaban. I usually don't ask about the other names. Apart from this, any name in the blood chapter, you should know it. Apart from the coagulants themselves. The coagulants themselves, this is too difficult. And you're getting, and the surgical stuff, this is used in surgery, this is difficult. I don't want it. But any proper drug that's used in the chapter of blood, you should know the name of the drug. Even the new antiplatelet drugs. Okay, so blood is very important. Okay, know all the mechanisms of action of and the suitable drug for each situation. Okay, there's a table in your book, I think, for a suitable drug for each situation for the anticoagulants. You should be able to differentiate which anticoagulant in which situation. Like, for example, a patient who needs very brief anticoagulation and a patient who will need very prolonged anticoagulation for months. What do you think the most suitable for the first case and for the second case? Heparin might be for the first. Warfarin might be for the second. You will not use warfarin for 2 days because these 2 days will not be enough to adjust the INR. أصلا. Okay? تمام? Patient with the DVT prophylaxis will take what? For DVT treatment will take what? For prosthetic valve will take what? Patient with, conversely, patient with stroke, recent will take what? Recent thrombosis will take what? Patient with severe bleeding will take what? Yeah? So anything in the blood chapter. Okay, exam is largely about the mechanism of action and uses. Know every detail about diuretics, especially aldosterone antagonists, even the new ones. I can't be more clear and elaborate. Aldosterone antagonists are very important drugs. Why? Because they are very important for patients with heart failure. So these are very important diuretics, and because they reduce mortality and because they reduce remodeling. And there are some recent ones. Aldosterone has certain uses, but it has certain side effects. And the side effects of aldosterone, where do they come from? What's so special about aldosterone that's making it cause certain side effects? It has a steroid nature, okay? So are they all the same? You're good. You're very good. Any Why drug acting on dopamine receptors is important? Whenever you see dopamine, this year, next year, whenever you see dopamine, just memorize whatever there is about dopamine. New hypolipidemic drugs are important, but actually, I'm very much interested in the ones I highlighted last time, like the PCSK inhibitors, okay? And I'm going to say a word about them. And the bempedoic acid. This is also important. These are new hypolipidemics. They are hypolipidemic drugs also are very important, and you should be able, because you know why? Because these two new ones are already in the market, and people are using them, and they are in the guidelines. Okay, time. Now let's go through the highlights, and let's okay. So as you can see, the highlights are straightforward. Okay. There's nothing particular to explain here. Side effects, main side effects of neostigmine and physostigmine. If you see them, you recognize them. Treatment options for myasthenia. Okay, symptomatic versus disease modifying, goal of therapy from each type, rationale for different treatments in case of myasthenia. Again, as you can see, I always ask why? Why does this drug cause this side effect? Why is this drug used in this situation? Always ask yourself why. Okay, side effects of anticoagulants and other drugs used in treating myasthenia gravis. Again, you should recognize the side effects of drugs used in treatment of myasthenia. Dynamics of atropine. Okay. Therapeutic uses of atropine, atropine substitutes. Okay. Adverse effects of atropine. This is all very important. Atropine is a very important drug. Classifying sympathomimetics. This is an area where I'm interested in chemistry, because chemistry has implications. How is chemistry, or what are the implications of chemistry here when you're talking about sympathomimetics? Huh? Catecholamines, non-catecholamines. Why? Catecholamines will be destroyed by MAO. Non-catecholamines will not be destroyed by MAO. Non-catecholamines might have the ability to pass the blood-brain barrier and cause CNS side effects. So these are all sympathomimetics. But the catecholamines are drugs, and the non-catecholamines are very different drugs. Sometimes you tend to forget that the non-catecholamines are sympathomimetics. Sometimes you get carried away that they cause CNS, blah, 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 blah. Remember, they are still sympathomimetics, and they can raise the blood pressure, and they can have cardiovascular action. This is important. As for the catecholamines, these are only for short uses. So you should know their uses and the differences between them. Okay, use of adrenaline, the treatment of allergy. Recognize tachycardia as a prominent feature of isoprenaline and how it impacts on indications and cautions. Of course, you know what is the most remaining use of isoprenaline? Heart block. Okay. Otherwise, isoprenaline. Otherwise, it's a bad drug. Why? Too much tachycardia, direct and reflex. And is tachycardia something good or bad? It is bad. Why? increases the effort done by the heart markedly, and what else does it do? Precipitates ischemia. And why is that? Because heart fills with coronaries filled during diastole. If you're making me tachycardic, this is my cardiac cycle, which is going to be shorter, the systole or the diastole. For the systole, I need to pump. I am consuming time. However, you're encroaching on my diastole. So you're encroaching on the time that the heart uses to fill the coronaries. So tachycardia is something very bad. You always want to get rid of tachycardia. So you use isoprenaline if your problem is bradycardia with heart block. Mention therapeutic uses of dopamine, phenoldopan. See, anything with the D is important. Describe the dynamics, uses, and cautions of the butamin as well. Explain how the chemical nature of ephedrine influences its kinetics. This is important, as I told you. It's as if, if you think of ephedrine and adrenaline, they are very similar in the mechanism of action. Okay, it's like you are taking oral adrenaline. However, this phenomenon of lipid solubility passing the CNS and escaping the effect of monoamine oxidase enzyme gets you different side effects of ephedrine. You see urine retention with ephedrine. You can never see it with adrenaline because it's very short acting. Okay, so it's a kinetics can give you a different drug. Possible clinical uses of amphetamine, okay, and amphetamine derivatives. Clinical uses, if we have any clinical uses and what they are. Describe the dynamics and kinetics of phenylephrine. Mention the therapeutic uses of phenylephrine. Again, nasal decongestants. Why am I very much fond of nasal decongestants? Yes, they are everywhere. Anyone can take them, and these are drugs. These are sympathomimetics. So even if you take them locally, you can have systemic side effects. This is one thing. Another thing is you can take something orally, okay, and it will be a vasoconstrictor, and it will relieve the nasal congestion. So there are oral drugs that can relieve nasal congestion, and even the locally acting drugs can have systemic side effects. Okay. Type. Mention possible adverse effects. Perfect. Shock. Now, reason of using everything. Why are you using each treatment? Remember, from the format of the questions, I'm telling you, I'm giving you explain questions, cross-matching questions. So these are about details. Details. Because when I put explanation questions and cross-matching questions, how am I going to do this? Unless I bring over details. Classifying sympathetic depressants, always the classification is very important. You have alpha blockers, you have beta blockers, you have central alpha-2 agonists. This is another form of sympathetic depressants. Therapeutic uses of alpha receptor blockers and sildenafil. That box, you know it by heart. Okay, that box for the alpha blocker uses, you know it by heart, please. Again, you have to classify beta blockers according to lipid solubility, receptor dynamics, selectivity. Therapeutic uses of beta blockers are always very important. These are very important drugs. They stood the test of time. Know the therapeutic uses by heart. Mechanism of antihypertensive effect of beta blockers. Again, this is very important. Okay. Special advantage of beta blockers with vasodilator actions. This is again very important because and a disadvantage of beta blockers if they are non-selective, okay, that they cause the vessels to be on the vasospastic side. And they have whole potions for this. So if you get a beta blocker with vasodilator property, you are sort of getting a double hit. The benefit of a beta blocker and the benefit of a vasodilator. This is marvelous. How can you get a vasodilator property? You should know. What makes a beta blocker having vasodilator property? Does it donate NO? Does it have alpha block as well? Does it have partial agonistic activity on the beta 2? So it will work the beta 2 as an agonist part of the time. So these are all very important. And by the way, the mechanism of action and these details that make you a good doctor, because you don't realize that in the medical field, you have many people working with you. Nursing, if they are well educated, they will be very well informed. Respiratory therapists, physical therapists, all these people, by the way, we teach them almost the same curriculum. But who's a doctor? A doctor who is at this level of understanding. تمام؟ طيب. Okay, explain the mechanism of action of drugs used in the treatment of closed and open angle glaucoma. Again, the treatment of glaucoma, it's a very common disease. Closed and open angle, two mechanisms, two purposes of treatment, two very different things. So you should be able to differentiate and know which drugs are used in which part. Skeletal muscle relaxants. Now I want to convey something to you. Or perhaps ask you a question. Let me say, skeletal muscle relaxant, neuromuscular blocker. Are they synonymous? What's the difference? Because you know, I discovered that some of my stuff, sometimes they forget about it. Glitches kid. Neuromuscular blocker, skeletal muscle relaxant. Are they the same? How are they different? Neuromuscular blockers are a type of skeletal muscle relaxants. Skeletal muscle relaxation can happen through neuromuscular block at the motor end plate, whether competitive or depolarizing. This is a neuromuscular blocker. Neuromuscular blocker working at the neuromuscular junction. However, you can still relax the muscle, okay, if you work centrally. So there are central muscle relaxants, central skeletal muscle relaxants. So you should be able to differentiate. And as I told you, classification is always very important. And the central muscle relaxants are very important. And I said this before, and perhaps I will say it again. I judge about importance by the frequency of use and how many specialties use this drug. Any doctor can prescribe a central muscle relaxant for a spastic neck, for something like that, many diseases. However, neuromuscular blocker will be used by whom? Anesthesia doctors and doctors in the ICU. Bas. No one else uses them. These drugs that can kill people, they can make people stop to breathe. Unless you have ventilation, intubation and ventilation, you cannot use a neuromuscular blocker. Okay? So uses of neuromuscular blockers, again, very important. Botulinum toxin in particular, whatever you have about it, know it, because it is in very common use now. And it's not just for cosmetic reasons. It is given for local injection for spastic areas, and it has many uses, okay? Describe forms of idiosyncrasy to succinylcholine. Again, anything mentioning idiosyncrasy, know it by heart. Why? Because pharmacogenetics is underestimated in our curriculum. It should have a better place, a bigger place. So anything talking about idiosyncrasy, know it very well. Commonly used spasmolytic drugs, mention the mechanism of action and comments of common spasmolytics and the mechanism of action and uses of dantrolene, one of them, a peripheral, not a central one. It's actually peripheral, working directly in the muscle. Now the autacoids, we need the uses and adverse effects of ergot alkaloids, renin-angiotensin system inhibitors. You should be able to enumerate or know which drugs exist that inhibit the renin-angiotensin system, because they are diverse. They inhibit the system by several mechanisms. So you should know التجميعة دي, you should know it. Mention therapeutic in applications of kinase and endothelin. Very little, know about it. Recent drugs, important now for pulmonary hypertension and so forth. Describe the therapeutic uses and clinical applications of prostaglandins. Very, very, very important. Diverse group of drugs, diverse uses, different applications. Please know their uses. Enumerate icosanoid inhibitors as well. outline the different treatment options for migraine. Again, whenever you have treatment options, you should know how many treatment options you have and which is the place of each treatment option. عندي 1, 2, 3, 4, 5, 6 drugs. One is used acute, one is used chronic, one is used to cure the disease, one is used to control symptoms. You should know this. Rationalize the use of different treatment options of migraine, okay, which is treatment, which is prophylaxis, which is specific, which is non-specific, adverse effects and contraindications and cautions of triptans, ergot derivatives in the treatment of migraine. Again, this is important because the cautions and the side effects might be very severe and you should know about them. And because migraine is common and you may see patients anywhere taking these drugs. Mechanism of action of diuretics in details. Diuretics is another chapter you should know by heart. Nothing in diuretics is not important. Nothing in diuretics is not important. All of it. Mention clinical uses of each class and compare the uses of thiazides with local potassium retaining and potassium retaining diuretics are especially important, as I told you in the beginning. As I see here, as you see, I'm highlighting again, explain differences among aldosterone antagonists regarding their endocrinal side effects and tendency to hyperkalemia. Can't be more clear. Describe the pharmacodynamics of organic nitrates, their mechanism of action, and their pharmacological actions. Again, by heart. Therapeutic uses of nitrates, by heart. Enumerate the adverse effects and cautions of organic nitrates, adverse effects of nitrates, by heart. Calcium channel blockers classification is very important because, again, these are different drugs. Nifedipine is very different from verapamil. Verapamil and diltiazem are anti-arrhythmic drugs. Nifedipine is not. It's a drug used for treatment of hypertension. Okay? Therapeutic uses of calcium channel blockers, again, very important. The role, mechanism of action, beneficial effect of each of the following in the management of angina. See, why is aspirin used? Why is ranolazine used? Why is ivabradine used? Why is trimetazidine used? Why is nicorandil used? Each one has a special reason. Each one of these has a special reason. So it's not just memorizing, we have these names of drugs. You know why you are using each of them. Beta blockers in management of angina, of course, important. Antihypertensive drugs according to their priority management of hypertension. Okay. First line, second line, okay. You took it already in the practical, but I cannot say you don't read it because it might come within some hidden question. So we cannot get rid of it. This is basic information. Enumerate inhibitors of renin-angiotensin-aldosterone system. Again, as we said in autacoids, describe the pharmacodynamics of angiotensin-converting enzyme inhibitors, how they work, and the advantages of their therapy in hypertension, okay, as compared to other medication classes, their side effects. As you can see, ACE inhibitors are very important, as well as the angiotensin receptor blockers. In heart failure, of course, as I told you, because I told you before, I'm going to ask you about acute heart failure in the practical. Now I have asked you about acute heart failure in the practical. خلاص. So now you concentrate on heart failure with reduced ejection fraction. This is what you concentrate on. You know the list of medications, blah, 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 blah. 9 of them. You know all of them. Each one. Why is it used? How does it give benefit in heart failure? Okay. So explain the beneficial action of each drug, clinical repercussions of kinetics of digitalis. Now, we didn't concentrate on digitalis for the end of module. Now is the time to read about digitalis. Okay, fair enough. Mechanism of action, actions, adverse effects. Oh, okay, arrhythmia. Arrhythmia has the same highlights because this was already very much abbreviated. Practically speaking, you were responsible for lidocaine and amiodarone, right? And honestly speaking, now, there's a problem with arrhythmia. We don't teach you arrhythmia in يعني we should teach you more about the treatment of arrhythmia, but I cannot fix this now. So I'm going to do two things. First of all, I'm going to refer to the arrhythmia chapter just for two small notes, And second is, after you finish your exam, just to be a good doctor, and before going to internal medicine, I had explained arrhythmia in details the days of COVID. And the link is there. It's not even on my page. Okay? So please listen to it. Please listen to it. Okay? طيب ها ايه يا جماعة بقى طيب so now let us have a look at the arrhythmia. This is your book. Now the thing is, this is the action potential of the cardiac cell, and the shape is different. I'm not going to be able to explain arrhythmia now. It is not the time. خالص. So if you're interested, please listen to the lecture because it's important for you. However, different phases in this action potential are responsible or are managed by different ion channels. So this upstroke is due to opening of the sodium channels and the sodium getting inside, or the depolarization. And then the repolarization is not like the repolarization of the nerve or the muscle. It goes in phases. So there is an initial phase of repolarization due to the exit of potassium. And then there is the calcium channels open, and the calcium starts to get in. So it's potassium out against calcium in. That's why we reach this plateau, okay? And then we have with the inactivation of the calcium channels, then the rest of the potassium or potassium continues to go out, and there will be repolarization. There is something also called the resting membrane potential, which is unstable in the pacemaker because there is spontaneous diastolic depolarization. So any drug that's affecting this upstroke or the sodium channels is going to affect excitability, is going to affect the conductivity, okay? Pacemaker potential, again, is managed by calcium channels. So action potential duration is another very important parameter. But anyway, what I want to tell you here is we are classifying antiarrhythmics here according to the channels, the types of channels they block. But there is a very important parameter for classification, which is their action on the action potential duration. So classification, like for example, the sodium channel blockers are subclassified according to their effect on the action potential duration. To cut a long story short, when you're using antiarrhythmic drugs, you are changing the way these channels open and close. So you might end one type of arrhythmia and get another type of arrhythmia. One very important property that makes a drug pro-arrhythmogenic is increase in the length of the action potential duration. Because during action potential, there is a refractory period which is initially absolute, but then becomes relative. So you can still get some excitation within this long duration action potential. type. Because we can't explain arrhythmia now. What I want you to know that there are some anti-arrhythmic drugs that can cause arrhythmia. So this is important. You should concentrate on this. This is one thing. Another thing is that we say here that group B, in which there is lidocaine, which is a very important antiarrhythmic, acts mainly on the inactivated sodium channels. Actually, it acts on the inactivated and the activated. And here is the proof. I have it here. This presentation was from Katzung's textbook of pharmacology. Lidocaine blocks activated and inactivated sodium channels because lidocaine does not prolong the action potential duration. So it has a very good action on the activated potassium channels that are making the upstroke. If it's going to block the if it's going to block the inactivated sodium channels, it should prolong the action potential duration. However, it makes very rapid dissociation from the channel. So, okay, it blocks the sodium channels that are inactivated by depolarization, but very briefly. It will just block the sodium channels when they are activated, and then when they become inactivated, very soon it will dissociate. That's why lidocaine will not prolong the action potential duration. And it is not known to be pro-arrhythmogenic, or it will not lead to this increase in the effective refractory period. So this is something about the book. What else? So still the classification is important, and you know the glitch about the classification, that something like lidocaine, it doesn't just block the inactivated, it blocks also the activated, because this is why it controls the, that's why it controls conductivity. So what else is important here? Also, amiodarone is important. And as you can see, it says here that sometimes it is pro-arrhythmogenic. So why is it called pro-arrhythmogenic? Because it might cause other types of arrhythmia. As you can see, amiodarone here has different classes of activity. It acts on the sodium channels, on calcium channels, on potassium channels. It acts on all of these. And so it might cause bradycardia, it might cause heart block. That's why it may result in other types of arrhythmia, and that's why we call it pro-arrhythmogenic. The problem is much bigger with other drugs. Amiodarone is relatively safe. Other drugs like drugs from class group 1C, these are truly pro-arrhythmogenic. That's why you don't see them much. They cause other types of arrhythmia. Okay, so otherwise you need to know everything about amiodarone. So we go back to the otherwise خلاص everything is like it was for the end of module. Now about the blood classification, I told you blood is your most important chapter. Anticoagulants, you have to know the route of administration. Of course, you should know whether the patient is going to be able to take this drug orally or it's only parenteral. Indications of unfractionated heparin, adverse effects of heparin and low molecular weight heparin and how it's different from heparin. Therapeutic indications of parenteral dry thrombin inhibitors and heparin-induced thrombocytopenia is very important, very important. It's a life-threatening situation. What is used for treatment, what causes heparin-induced thrombocytopenia, and how to treat heparin-induced thrombocytopenia from whatever in your book. Describe initiation and monitoring of warfarin therapy. How do you initiate it? How you monitor it? Mechanism of action of new oral anticoagulants and advantage of these drugs over warfarin. Antidote of each anticoagulant should be known. Mechanism of action of different classes of antiplatelet agents, everything here. Okay? Even the new drugs. Pharmacological basis behind prolonged antiplatelet action of aspirin. Of course, you know that. Why aspirin action is very prolonged? Because it is an irreversible inhibitor, okay, of the thromboxane A2. So what? Platelets don't have a nucleus. They are just packed with their enzyme. They are not cells. They don't have nucleus. However, the endothelium can regenerate its prostacyclin. So here there is an imbalance to the benefit of prostacyclin, which is released from the endothelium. Okay, so there is always decrease in platelet aggregation. Action of aspirin remains for the whole lifespan of the platelets. It's for 7 to 10 days. Of course, it becomes weaker each day if you stop aspirin. However, you can get some action until 7 to 8 days, 7 to 10 days. Fibrinolytics are very important. Mechanism of action, differences between them. Which of them is safer than which? And their indications. When do you use fibrinolytics? Okay, mentioning indications, adverse effects of fibrinolytics, and comparing anticoagulants regarding their approved therapeutic indications. It was in red, and it is still in red, and it will always be in red. When to choose which anticoagulants for which situation. Mechanism of action of different classes of anti-hyperlipidemic drugs, and comparing them regarding to side effects. Let me now show you something. Okay, perhaps this is because these two new drugs So do you know how the PCSK9 inhibitors work? You know them? Type. What's the problem? What's the problem with cholesterol? Why do you need to reduce cholesterol osman? What's the problem? What will happen to those patients? Huh? What if you did not treat atherosclerosis? Or what if you did not treat high lipids? You left cholesterol high. What will happen? Lipids are very high. You have two very bad things that can kill the patient. Atherosclerosis, this is one thing, and pancreatitis, this is another. Acute pancreatitis. So you have two important complications. Now, for atherosclerosis, what will happen? So what? Coronary heart disease. So this is one of the examples where observational studies were very important. There was a very, very big observational study called Framingham study. Anyone knows about it? Framingham study. In this study, you know what's an observational study and what's a clinical trial? Clinical trial is when you divide people, you randomize them, okay? And you're doing an experiment on human beings. Observational study is when you just observe. So what happened in Framingham? They decided to observe 1/3 of the population of a city called Framingham, recording data about everything. And this is where we got what cholesterol values we need to keep for patients to protect them from acute coronary attacks. Because by analyzing these data, they said, okay, what is the probability of having coronary heart attack within 10 years? And then they associated this with the cholesterol level and with other risk factors. So you have calculators now. They will ask you, what are your risk factors? Are you a smoker? What is your age? Are you a male or female? Are you female if you're menopausal or not? Do you have diabetes? Blah, 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 blah. And it will calculate your risk for having okay, for having a heart disease or a coronary event within 10 years. How to reduce this risk? The reduction in this risk is associated with a certain level of cholesterol. I know this is a long story, but I am getting into something. I will reach my target. So, to decrease this risk, we need to bring down your cholesterol low. So here we are not treating a symptom. There is nothing painful that we are treating. There's nothing that we see that we will treat. We just want to bring down your cholesterol. And we will bring it further down the more risky you are. The more risk calculation you have, the higher, the lower will be your cholesterol. It's not your normal cholesterol. Sometimes the lab will tell you this cholesterol is normal, but it's not good for you because you have a high risk of coronary artery disease. So you should bring your cholesterol down. So what? I will bring my cholesterol down. We have what drugs? Main for cholesterol reduction? Statins. They will remain wearing the crown of cholesterol lowering. خلاص, we can all take statins. However, statins might not be enough. That's why hypolipidemic or anti-hyperlipidemic combinations are important, because sometimes the drug needs statins and needs a second drug and needs a third drug. And why is this? Because we are looking at a cholesterol target, a number. We need to bring this cholesterol down. Sometimes LDL cholesterol should be below 70. Okay, for some people, and it will be kept below 70. So sometimes you need 1 drug, 2 drugs, 3 drugs. Guys, another problem. You know what's another problem? What if this patient is not tolerating statins? What does it mean, not tolerating statins? Like what? Like what? 2 most important side effects of statins. What are they? Elevated liver enzymes and rhabdomyolysis. And what does the rhabdomyolysis do? No, this is not the most important thing. Acute renal failure. Rhabdomyolysis means no kidney. Rhabdomyolysis means myoglobin accumulating and blocking the kidney. But even before this happens, some patients, they can tolerate. What does it mean, the word non-tolerating? This is a word, this is a term. Not tolerating. They have side effects that prevent them from continuing on the drug. Some patients come with severe muscle pain, not weakness, muscle pain. They cannot continue on statins. Drugs are very effective, not high price drugs, many members, yet sometimes they are not enough and sometimes there are side effects. So you should have options. And this very long story is to tell you, you should know about all your available options. And some of the recent drugs are bempedoic acid and PCSK inhibitors, PCSK9 inhibitors. So these are the PCSK9 inhibitors. This is a very known game. Most of the hypocholesteremic drugs play the same game. Now, is cholesterol good or bad? Is cholesterol good or bad? It is good. يا جماعة احنا all our hormones are أصلا cholesterol, the steroid hormones. احنا we need cholesterol for the cell membrane. We need cholesterol. However, there is some problem here because cholesterol is too high. We want to make it low. The liver makes the cholesterol. So what do these drugs do? They just, all of them, they prevent the liver from making cholesterol by different ways. And when the liver cannot make cholesterol, where is it going to get it from? It's going to upregulate the LDL receptors and it's going to get cholesterol from the blood. And this is the game. This game is played actually by statins and it's also played by Bempedoic acid. There's, I'm sorry, the image is not very clear. I couldn't get it clearer than this. The bempedoic acid is inhibiting, okay, this trait-lyase enzyme, which is an early enzyme in cholesterol synthesis. So this is the mechanism of action of bempedoic acid. So this is one drug. Another drug is, these are the PCSK9 inhibitors. These are, the problem with them is they are monoclonal antibodies. Of course, you know, if you see the name, I'm not making you responsible for drug names, but if you see the name of a monoclonal antibody, you know it, right? Okay, so these are monoclonal antibodies. Okay, what they do is, this PCSK, what it does is it results in down regulation or produces down regulation of LDL receptors. So these monoclonal antibodies, they are against this PCSK9, which down regulates LDL receptors. So if I'm going to inhibit these antibodies, what is going to happen to the receptors? They will not be down regulated. There will be a lot of LDL receptors, and the cholesterol is going to be internalized in the liver, and it's going to decrease, its level is going to decrease. These drugs are monoclonal antibodies, meaning they are very expensive drugs, yet these drugs are used and they are in the guidelines because sometimes statins are not enough, and sometimes patients cannot tolerate statins. So what? You need to decrease cholesterol, and you need to keep it at a certain level, which is proportionate to what? The risk of that patient in developing coronary artery disease. How do you know this? You have calculators, you just enter. By the way, this is even for you. Anyone at the age of 20, sometimes even, I'm not sure about the guidelines, I think maybe even younger, you should screen yourself for hypercholesterolemia because it's silent and it's familial and it runs in families. Some children have hypercholesterolemia. Everyone should be screened for hypercholesterolemia. And of course, whether it's you or anyone you care for, you should calculate this risk and know your cholesterol target. Type. We go back to our orientation. Ida, we have finished. There's no anemia. Okay? Tamam? Any questions? I'm going to upload this tonight, okay? And I'm going also to upload the presentation. And okay, I'll just stop recording and